All right, thank you so much for staying with the Monday Report. Town Hall session begins right now. Special thanks to the Panari Hotel for hosting us this evening. We're returning the microphone back to the people. This is a session where they ask their questions in their own way and get their answers from the specialists that we have with us here in studio. Let me introduce them really quick, starting from my immediate right. Dr. Uma Luga is here. Thank you so much for making time.
Thank you, Trevor.
Dr. Luga is the Director for Health Services at NMS. Asante sana for making time. Dr. Maribeth Maritim is also here. Thank you so much for making time. She's the co-chair, Kenya National Immunization Technical Advisory Group, usually known as KENITAG. Asante sana for making time. And Dr. Andrew Mulwa, Director, Medical Services, Preventative and Promotive Health at the Ministry of Health. Asante sana for making time. They will get to answer all your questions in regards to the COVID-19 jab. What is the recommended age for the jab? Should you mix and match? At what intervals should you take the booster shot? Is it recommended for pregnant women? All those questions will come from the audience to them. We'd also like to hear from you at Trevor Mbidi at Citizen TV Kenya. Use the hashtag Monday Report. In fact, let's begin right there. And I'll start with you, Dr. Mulwa. There's a circular. I was speaking to some of the parents earlier on, and they said there's a circular that came from the government asking parents to consent to the immunization of children below 12 years old. What is the recommended age for vaccination? And was there a new circular from the government?
Yes, I think, the Ministry of Health, working with KENITAG, where Dr. Maritim is a vice chair, advised the ministry to lower down the vaccination age from 15 to 12 years. Which is indeed in line with the global practice. In fact, in some communities, in some countries, they have gone as low as 5 years. But because we are balancing between the availability of the vaccines and the population, we moved down from 15 to 12. Of course, remember, when we began this vaccination, Kenya is undertaking a phased vaccination. We began from the high-risk groups, healthcare workers, the elderly, people with comorbidities, moved down to people with disabilities, now expanded to the rest of the population above 18. We moved from 18 to 15 and now to 12. Probably in the coming months, we may review even lower down to even 5 years.
Okay.
These vaccines are safe across the population cohorts that are getting. And elsewhere, from practice elsewhere, yes, vaccines have been administered to even children from 5 years and over.
Yeah. Dr. Maritim, what informed that advisory to the government? And do we know the effects of the vaccines to a younger population?
So as a member of KENITAG, KENITAG is an independent group of experts that advises the Ministry of Health and the government of Kenya on all matters vaccines. So we look at evidence that has been generated. We look at data from clinical trials, and based on that data, mainly the data that's looking at safety and efficacy and the protection that's offered by the vaccines, we're able to find enough evidence to make the recommendation. So based on that, we're able to recommend vaccination of children. So currently, the recommendation is for people who are aged 12 years and above to receive the vaccination. And the data that we have are mainly for vaccines that are based on the mRNA technology, so mainly the Pfizer and Moderna vaccines. Those are the ones where the evidence is for using children aged 12 and above. That's the recommendation for Kenya. And as Dr. Mula has also mentioned, some other jurisdictions and other countries, particularly Western countries, European countries, are vaccinating even children below 12 years. But because of issues of equity and balance, because we know also we have a large population that is can be vaccinated. So we have to balance the availability of the vaccines vis-a-vis the population. Yeah. So we have enough evidence in terms of safety and efficacy to actually make the recommendation.
Let me take you back to what you just mentioned. So it's only Pfizer and Moderna for children below 12.
Yes, that's where a lot of the evidence is based on clinical trials. As you may remember, some of you maybe who have followed the COVID vaccine science, when the vaccines were already being deployed in adults, initial clinical trials did not include children. So once the vaccine were proven to be safe and efficacious in the adult population, then the companies actually commissioned clinical trials to lower the age group, and based on the evidence, then they were able to generate enough data, and actually these vaccines are FDA approved for the pediatric population.
Okay.
Yes.
So parents who are listening today should stay away from AstraZeneca and the rest?
Yes,
for children
we don't
below the age of 12
have clinical trial data to support AstraZeneca. And
Okay.
even at the moment, we don't have AstraZeneca vaccines in the country. They've been out of stock for some time.
Okay.
So the vaccines that are currently available are mainly Pfizer, and that is safe for use in the pediatric population. So even when we made the recommendation for Kenitag, we specified the specific vaccine for use in the pediatric population, the mRNA vaccines.
Okay.
Yes.
Dr. Luga, what is the status of vaccination right here in Nairobi, and what is the plan going forward?
Thank you very much, Trevor. So first and foremost, for us in Nairobi, we want to thank our population because we have had a lot of reception. Right now we are at 53% of adult population that is fully vaccinated. We've delivered close to 3.5 million jabs. But as you note, Nairobi also plays quite a critical role in the prevention of disease entry into the whole country, because this is the hub of transport. So there are around 10 transport corridors that serve all the 47 counties here in Nairobi. And so we see our role also as very critical in terms of minimizing transmission of COVID-19 from Nairobi to the other counties. And that is why we would still recommend for the 47% of Nairobians who have not yet received the vaccine to do so. We are targeting 3 million adults as at now, and also out of these 3.5 million vaccines that we have administered, as I've mentioned, some may not have been people who stay in Nairobi. And so because of the high migration in and out of Nairobi, we are always in the constant lookout for new people who fall within the categories that have been in the policy. Basically, for us is people above 15 years. And right now, particularly the younger people are the ones that we are targeting more, because people in colleges, adolescents and youth that are below 35 years of age. And then there is, of course, hard to reach areas in the informal settlements. We have nearly 275,000 people who got the first jab but did not come for their booster, the second and even now booster shots. And then we have also Nairobi being Nairobi, it's also the place of disinformation. So we are also really targeting the people who are spreading false information, and especially those who are in positions of where they can be believed and are either misleading populations, because we know that this also is playing a very critical role in the hesitancy, if you'd call it. The 53% are the people who are self-willing and also easy to reach. But now we have reached that plateau where we now have to go out aggressively to look for the other 47%. And it takes a lot of effort, and that's why we are here today, just to continue championing the safety of the vaccines and to mobilize everyone that COVID-19 is still here with us, just like, of course, there were Ebola outbreaks before, but then now you see the resurgence, and it could be the same with COVID-19. I think one important thing I want to mention just as I close that you see, for us in Nairobi, out of all the deaths that we had, 27.4% of all those deaths were here in Nairobi. And that changed the top 10 morbidity and mortality a bit. In fact, when you look at the morbidity chart, basically the top 10 diseases that we have, in the last 2 years, COVID-19 comes as number 2. 85% of those cases may have been mild, 15% of those cases may have ended up in hospital, and even the 1.1% with the ones that we are talking about as deaths. But you see that has changed, that has altered that chart. And so for us as a public health intervention, it's very important that we are very clear on protecting the whole population in Nairobi, but more importantly, looking at it from the broader perspective that protecting Nairobi also protects the whole country, because this is the origin of many transit.
Yeah. Interesting views there. Let's bring in some of the perspectives from the people and the questions they're asking before I get live questions from my audience here. There's quite a number who sent in their video questions. Let's hear what they have to say.
This COVID virus was attacking especially these people whose immunities were weak. So that is why I took the vaccine, because I wanted to improve my immunity. And there's nothing wrong with a healthy immunity. Now, even after the vaccine, I still continued eating healthy. Greens na hizi vitu zingine zote. Because if it is not this virus, another virus will come. And if your body's immunity is weak, then you will succumb to it.
Sijachanjwa bado. And the main reason is because a few of my friends walichanjwa and it had some reaction with them. They were vomiting, high fever, and hawakusikia vizuri. So per my thought, I was like, I'm not going to start chanjwa pia mimi because I don't want the same reaction.
Mi kulingana na mimi niliona hiyo chanjo haina maana, kwa sababu mi ni Mkristo, ninaamini ya kwamba hakuna jambo ambalo ni gumu mbele ya macho ya Mwenyezi Mungu. So hiyo ugonjwa ikikuja ingie kwa mwili yangu, niite Mungu, ninapona.
Yes, I've been vaccinated. No, I didn't really care about the misinformation. I just thought that if it's something that is going to help us just to prevent it, like, and it gives us like an immune. So I thought it was okay for it to, like, it's okay to take it.
Mimi sikupata chanjo, na sababu ya kutopata chanjo nilienda mara 3 nikikosa. Sasa vile nikakosa nikashindwa, kwani Mungu hataki nichanjwe? Na nilikuwa nimesikia ripoti watu wanachanjwa, wengine wanakufa, wengine wanagonjeka. Sasa mimi nikaogopa pia.
Kwa sababu sijagonjeka na ilikuwa ni chanjo tu kuzuia. Kwa hivyo ilikuwa ni lazima ni chanjwe kwa kuzuia. Na haikuwa ni mimi peke yangu, ilikuwa ni kitu ya dunia nzima. Sasa upande yangu singeweza kukataa nisipate chanjo.
Sikupata. Mbona sasa? Kwani niliogopa kuchanjiwa. Juu nilikuwa nimeshikangwa wakati mwingine nikaambiwa niko na corona. Venye nilienda huko Lang'ata hakuna usaidizi nilisaidiwa nayo.
Chanjo nilipata kwa sababu ilikuwa ni tahadhari ili tujikinge tusipate, yani tuweze kuongeza kinga ya kuzuia maambukizi ya virusi vya Covid-19 kutupata. Sasa kwa sababu ya kuchukua tahadhari ilibidi nidungwe.
Okay, at first before niende chanjo, like literally I was so scared. It was like it can backfire and stuff. Like people have so many things in their mind, so like it can backfire and stuff. What will I do? Yeah, stuff like that. But I was like, let me go get it.
All right, those are the views from the people in terms of concerns. And Dr. Mulu, I'll start with you. One of them talked about the lack of vaccines. They're saying they tried several times and they were not there. Are they available now, and where can they get vaccinated?
I think, I really truly understand that the COVID-19 vaccination has gone through a journey where the vaccines were initially not available, and we lost a big opportunity where at the opening of stations, we would actually have thousands of Kenyans lined up to get the vaccine. At the time, because of global supply logistics and of course there was a marginalization of the poorer countries and vaccines were not readily available, we lost that big opportunity at the beginning because we did not have the vaccines available, and some people went to the facilities and they could not get the vaccines. That is indeed very true. But the situation has progressively improved. In fact, for the last 1 year, we have enough vaccines. I would say we have enough vaccines. We have had to deal with expiries of vaccines. Of course, you remember the Cabinet Secretary declaring close to 1 million vaccines in March were expired. We also have enough vaccines in the country right now. In the pipeline, those that are in the country, in the central stores, in the counties, and in the regional stores. But in the pipeline from the global supply chain, we have a lot of vaccines that we are holding so that the demand improves, so that we are able to accept the vaccine to come into the country. So we also had a challenge. We began with each county had like one facility that was vaccinating. Now we have moved from one facility per county to 800 to now 3,000 and to now 8,000 facilities in the country. I think literally all routine immunizing facilities are now immunizing against COVID-19. The other issue, and this also has contributed to lack of uptake of vaccines, is even when we have these vaccines in the facilities, it is asking too much of an ordinary citizen who is unwell, who is not unwell, who is healthy, to walk into a facility. They imagine the queues, they imagine all that. So as a delivery mechanism, as a ministry, we have been working with our partners to have outreaches and take the vaccines where the communities are. We have seen this from the various campaigns that we have done. Of the 22 million doses that have been administered, 3.8 of them were actually done in 17 days. And in the last 2 months, we did a campaign and delivered close to 2 million vaccines in 10 days. In other words, going out to where the population are changes the dynamics in terms of, because by the time someone gets to the facility, they have to get a means of transport that will cost them money. They have to imagine queuing. But when you go where the population is, the uptake has been promising. Okay. So I think now the vaccines are available in literally all vaccinating facilities, 8,000 plus of them. Yeah. The vaccines are available, but we still have to do last mile approach, where we go to the communities and rather than wait for the communities to come to us.
Okay. And Dr. Maritim, do we know which ones are more effective now? There's been a concern from different people saying that they've seen some side effects, sometimes even death. That's the reason why they couldn't go. And you've mentioned for the younger population, Pfizer and Moderna has been tested. Do we know which ones are more effective now? And do we even know at what intervals should someone get a booster? Is it now monthly? Is it 3 months? Is it 1 year?
Yeah, so thank you for those questions. And I'll take them first addressing the safety issues, and then I'll look at the efficacy, and then look at the boosters and the interval for the boosters. So with regard to safety issues, most of the vaccines that we currently have, and in Kenya we are administering, we've made a recommendation on 5 vaccines. So we have the Pfizer vaccine, we've had the Moderna vaccine, we have AstraZeneca, we have Sinopharm, and then we have J&J. And I know many people are familiar with Johnson & Johnson, which is given as a 1 dose. And I think many people, that's the vaccine that has moved fairly fast because it's a 1 dose. People believe that it's easier to go and receive 1 dose. So in terms of the vaccines that are available, when we look at efficacy and effectiveness, so efficacy is derived when the vaccines are undergoing clinical trial, and you design the trials to be able to see how many people who are vaccinated develop infection, and one of the other outcomes would be are hospitalized following the infection. So by and large, all these 5 vaccines that are currently available or have been available and administered in Kenya, they have very good efficacy, and they have fairly good effectiveness. So effectiveness is when you deploy the vaccine in the real world setting, how many people is it able to protect from severe illness, particularly hospitalization, and to avert death. So when you're looking at vaccines, those are really the most important outcomes, because as it is, none of these vaccines entirely prevent transmission of infection, but we look at the outcomes in terms of preventing death and preventing hospitalization, because when someone is hospitalized because of COVID-19, they incur a very high bill, and sometimes they may not survive and end up dying. So those are the worst outcomes. So by and large, all the 5 vaccines that are recommended have a fairly good efficacy and effectiveness in the real world. With regard to the safety issues, so when you give the vaccine, you are giving a foreign material that mimics the virus, and it works in the body to produce an immune response that's able to protect the person who's vaccinated. So it produces antibodies. In some cases, it also produces protective cells that's able to ward off any viral, the SARS-CoV-2, the coronavirus invasion. So that is the expected effect of giving the vaccination. So the vaccine is administered through an injection on the forearm. And one of the ways of even knowing that you're mounting an immune response or you're developing an immune response is you'll develop things like pain over that area, swelling over that area, discomfort over that area. And it actually shows you that that vaccine is being taken up by the immune cells. So that is expected. An extension of that is you may develop some other effects in the body. You'll develop something like fever, which is hotness of the body. You'll develop headaches, you'll develop body aches, which is just a sign that the immune response has moved away from the arm where the vaccine was delivered to the rest of the body. So those are expected side effects, and we see it even when we take the children to receive the vaccination. For those of you who have been mothers and have taken or you've been vaccinated, you expect those local effects as well as even systemic effects. There are some extension of those effects that may not have been anticipated, and that's why when the clinical trials are conducted, we have safety indicators that help to identify some serious events or what we consider serious side effects, which may require someone to be hospitalized. And this, when the clinical trials are designed, sometimes the numbers are too small to identify some of these side effects. Yeah. But when you deploy the vaccines to a larger population, then you're able to identify. And in Kenya particularly, when we deployed the vaccine, the Pharmacy and Poisons Board, through the Chanjo system, was able to track people who had side effects that were not expected, and people have an opportunity to report these side effects. Yeah. They can report it in the facilities where they receive the vaccination. They can report it electronically through the Pharmacy and Poisons Board system. There's what is called pharmacovigilance electronic reporting system, and then they can also report it directly through the Chanjo system. So these indicators are tracked and they're analyzed, and these are within the Ministry of Health and the immunization program. There's a safety committee that sits and adjudicates some of these safety concerns. The other question you've asked is around the booster, the booster and the intervals and duration of protection. So when these vaccines have been deployed, they've really been deployed in the setting of a pandemic, but there's been a lot of work to try and understand what is the duration of protection of the antibodies that are formed following first natural infection, and even for people who've been vaccinated. So on average, it's thought that the immune response lasts about 6 to 8 months, and the current recommendation is to give boosters every 6 months or so. So in the recommendations that we've made for the country, people who've already received, before I go to that point, so because we are giving different vaccines, so for the mRNA vaccines, which is the Pfizer and Moderna, there are 2 doses that are part of what is called the primary vaccine dose. So these 2 doses are given 28 days apart. So you get the first dose, and then you get a reminder 28 days later to go for your second dose. So once you finish the 2 doses for Pfizer and Moderna, it's considered that you finished your primary dose. The same thing with AstraZeneca vaccine. I received AstraZeneca way back. It was the first vaccine in the country. So you have also 2 primary doses, 8 to 12 weeks apart. So you receive your first dose, and then 8 to 12 weeks later, you get a reminder to go for your second dose. And those 2 doses are what is called the primary dose. Yeah. For Sinopharm, again, 2 doses, 28 days apart, just like for the mRNA vaccine. For J&J, the primary dose is considered to be a 1-dose vaccine. There's been newer evidence to suggest that you may actually need 2 doses, but the current global recommendation still remains that it's a 1-dose vaccine. So once you received your primary doses, because we've said the duration of that protection that is offered lasts for about 6 months, it means, therefore, within a period of 6 to 8 months, your immunity and the antibodies that your body had developed, the protective levels start to fall, and you need another shot, what is called the booster dose, to improve your immune system. And that's why the recommendation is to give boosters every 6 to 8 months. So we've actually made that recommendation. And because the time has lapsed since we started deploying the vaccines in Kenya, these vaccines were deployed from 5th of March 2021. And we targeted the vulnerable population and the high-risk population who already qualified for their booster. And even in the new recommendation we made, we actually recommended that they can go for a second booster because that we know that their vulnerability is ongoing, and therefore the antibodies have declined and they require another second booster.
So 6 to 8 months?
Yes.
Okay, before I bring in Dr. Luga, Dr. Mulo, do we have enough for 6 to 8 months if people now decide to come after 6 months?
Yes, we have enough.
Okay.
In fact, the problem is no longer the vaccines in terms of the supplies.
Okay.
The challenge is the people are not coming. We are not getting the numbers to consume the vaccines that we have. We still have vaccines that are at risk of expiry.
Okay.
We have a lot of vaccines in the country.
All right, Dr. Luga, you're the one who talked about misinformation. You've heard the people who are speaking earlier on saying sometimes they get attacked because they have weak immunity. Others saying they're Christians, therefore if they pray, they'll be fine. You'd also mentioned that you're now targeting the younger population to be vaccinated. Earlier on, when this vaccination drive began, you were targeting the older generation who are most vulnerable. Why the change of heart?
It's not necessarily a change of heart. First and foremost, it goes back to the Ministry of Health protocols that have also been being rolled out or disseminated to county governments, so generally to implementation practices like ourselves. And as Dr. Muller had already mentioned, because of the global supply chain, the first vaccination phase was for the high-risk groups, and the high-risk groups were the people who are elderly and those who have comorbidities that would make it easy for them to either get COVID or easy for them to be hospitalized or easy for them to die when they get hospitalized. And then, of course, the people who are in high contact with the population, and also the people who are in high contact with those who may have COVID, that is the healthcare workers, the police, the teachers. So that was the groups that were being targeted initially. So it was not necessarily that we've changed heart. It is because now we have, for example, we have here in Nairobi, we got to around 72% of healthcare workers, which in a population, once you get to 70%, you really consider that you have really vaccinated a population large enough to protect that particular population. Teachers, we nearly got to 68%. The policemen and the disciplined forces, we were above 60%. So that means that those populations are no longer at risk. The elderly also here in Nairobi, initially we started with those who are above 58 years. And as we speak right now, we are around 62% of 61 or 62% of those that are above 58 years. So you can see the progression in terms of reach out. But when it comes to the younger population, and that is those that are below 35 years of age, we are barely doing 10-15% in terms of vaccinating that population. Yet that population is still at risk of getting COVID. They may not get hospitalized, but then they are the same ones that are spreading it to the high-risk groups, you know. So in terms of public health intervention and planning, it is important that right now we target that population so that we even protect the ones that we have vaccinated. And something that you have mentioned that is also very important is that this is also the group that is more susceptible to the misinformation. One, because they may not have suffered the adverse effects of COVID-19. Some of them may have, like for healthcare workers, we lost very young healthcare workers during that time. So for healthcare workers, we know we can even name people who passed on, who are young, who are less than 35 years of age or less than 40, some of whom were in their 20s. But for majority of people, because, for example, universities were closed, colleges were closed, they may not have really had effect, except, for example, those either whose parents or loved ones went through this horrible period of hospitalization, ICU, those who are getting bills of 5 million. So the younger people are also the ones that are more susceptible to misinformation, because sometimes you have people who may not have face-to-face experience with the damage of COVID-19. And also because the younger people were affected, but they were affected economically. They were affected in terms of loss of jobs. We had nearly 1.7 million people who lost jobs. They think that maybe some of the measures that were taken during that time were more of, because they are not seeing themselves as sick. So, but then the hotel is closed, so they are no longer going there to wait. So they may have a negative perception of the whole measure, curfews that were there, so they are looking at it as their enjoyment was curtailed. Transports were not there. So they may have a negative perception. But right now that we are in an environment where we are open, we can reach out to them and teach them about, number one, of course, the importance of protecting themselves against COVID-19, but also what the significance of that means to the whole population.
Yeah.
And that's why it is very important for us that younger people right now, because we no longer have the curfews, we no longer have the transport restrictions, we no longer have bars and restaurants that are closed, that now it is just about the information on the disease and why you need to get vaccinated to protect yourself and protect those that you love and protect the whole population.
Yeah, there's a general nonchalance of taking the vaccine because we've seen the death toll somehow reduce. In fact, people are saying COVID deletion. Yeah. What is the situation? I'd like to hear what Dr. Mulu has to say on this.
Yes, indeed, that is very true, that the perception out there about the risk of COVID-19, because from January, we have had very, very low fast positivity rate. So to speak, the last 2 months, we have had a positivity of about 1%. So almost nil deaths in a month. So that low risk perception, of course, makes a lot of people believe we no longer have COVID, and therefore it's no longer important to get vaccinated, which is a misconception. The one thing that I continue to believe is vaccination has really played a very big role in containing the pandemic as it is, because by having the frontline workers, the healthcare workers, close to 95% have had their vaccines. The elderly, above 60% have had their vaccines. This is what has kept actually the pandemic low in our setup, and therefore it is important to continue recognizing that the pandemic is still here with us. That 1%. Remember, we closed schools and everything when we had one case. So the 1% that we talk about is probably 10, 15, 20 in a day. So it's still a very significant number. And there are economies that to date are still under restriction because of COVID-19. So therefore, it's important to have the herd immunity that we so seek to acquire. And the ministry's plan is to have 100% of adults, which is 27 million persons, vaccinated by the end of December this year, and 50% of younger people, adolescents above the age of 12, vaccinated by end of December. Ambitious targets. Of course, with the current trends, we have seen that the game changer is one, sustained communication. Because we have learned from experience that if we slow down on the communication, the population also slows down on the uptake of vaccines. So if we do mass campaigns or outreaches, and I mentioned the statistics, how we've been able to get 3.8 vaccinations within 2 weeks and 2 million vaccinations within 10 days. Clearly what that means is it is how we structure the delivery system. Sitting to being passive. In other words, being passive and waiting for the people to come for the vaccines will not happen. The important cohort that we need to engage is young people. Young people between the age of 18 and 35 contribute a significant population, portion of the population, more than 50% of the population, and they are the population that have not taken the vaccines. One, because of the it's false belief that they are protected because they are young, they are unlikely to get severe disease, which is not true, and Dr. Oluga has already mentioned that. Then secondly, because they have access to a lot of misinformation, especially through social media. This is the cohort that is in Twitter, that is Instagram, that is all over. So they are able to access all this information. And the global anti-vaccination campaign is a big movement. In fact, if you recall a few years ago before COVID, We had a movement against tetanus vaccine in expectant women. We have had a major campaign against vaccination, even in the routine immunization. So I think it is now how we innovatively re-engage the younger people to take up the vaccination and drive the demand amongst them. Otherwise, the vulnerable, which is the elderly, with comorbidities, and the frontline workers, majority of them are above 70% in terms of vaccination rates.
Okay, I have some of them with me here in the audience. In fact, let's hear their concerns from them directly. And you have the microphone. Start with your name and then state your concerns or your questions.
Okay, thank you, Trevor. My name is Kipkorir Alan, and I want to pass this question to Mr. Mulwa. Of course, COVID-19 came with a lot of challenges, one being loss of lives. So as the Ministry of Health, what are the measures that you've taken to convince people that it is important to take a vaccine before you are affected with this COVID-19? So what are these measures that you've taken? And which are these measures that you've taken that have worked out? Okay. Then my second question is, we've heard the Ministry of Health saying that there were some vaccines that expired. How did these expired vaccines affected the Ministry of Health? What were the impacts to the Ministry of Health?
Yeah. All right. Let's take the questions in threes so that you can pass the microphone back there. There's a lady with a microphone. I see there are quite a number of questions. Korir, you can pass the microphone to her. Yes, over there. Mention your name and then your question.
My name's Maslin Nairuka.
Hold the microphone slightly higher.
My name's Maslin Nairuka. Outside there, parents think that the vaccine is not good for the children at the age of 12. They think that the vaccine is not good and it reduces the lifespan of the kids. What can you tell them?
All right. All right, you can pass the microphone. There's a lady here with the microphone. Yes, we'll take them in threes. So the third question, and then I'll come to the next set. Yes, go ahead.
Thank you, Trevor. My name is Maureen Asmiu. I have three questions. The first one is about the AstraZeneca vaccine. News are that the AstraZeneca causes blood clot. And I'd love to get a clarification on that. And then if there's a blood clot, what do you do? And then the second question is that if there are COVID vaccines, can we also get vaccines for common colds and flu? And then the other question is a normal Kenyan who has taken the 2 vaccines will ask why is it necessary to take the booster shots? Because they took the 2 vaccines, and the body is supposed to develop antibodies to fight them. So meaning, are they at risk of contracting COVID if they took the 2 doses of vaccine? What is the need of taking the booster shots if they took the vaccines?
Okay.
Thank you.
Brilliant. So let's take those questions. You have to be very brief with your answers because it seems there's quite a number of them. I'll start with you, Dr. Mulwa. Measures taken to convince the people?
I'll begin by the measures taken. I think we have taken a whole society approach. Of course, the COVID-19 vaccination, we no longer do it as a Ministry of Health, but our whole government approach, involving all sectors of society, religious groups, community leaders, and we have done sensitization, we have done education, we have done at the grassroots community level. Working with the county governments, that we have ensured that the community health volunteers are the ones leading. For expiries, any expiries that we get are discarded in a safe way. We don't administer expired vaccines. Any vaccine that expires is removed from stock and destroyed in an appropriate manner. The issue about myths about, and Daktari, I'm sure you'll be able to speak about shortening of lifespan of children.
That one is for Dr.
Which is we actually, all of us seated here probably exist because we have taken certain vaccines in our childhood. Vaccines have actually contributed to the growth of the life expectancy of the global community.
Okay.
Minus the vaccines, under 5 mortality would actually be higher, because we are, all of us seated here, a few years ago, when we did not have the pneumococcal vaccine for pneumonia, you would go towards, and all the children would go find wards full of children with pneumonia. The rotavirus vaccine against diarrhea, children were dying of diarrhea. When these vaccines were introduced, we no longer, actually, I cannot remember the last time I saw a child with very severe pneumonia.
Okay.
Something that used to be very, the other thing about vaccines available for flu, indeed, even here in our country, influenza vaccine is available. It is administered on an annual basis in most economies. So, and I think that is what will happen to the COVID-19 vaccine. That is a vaccine that will be administered routinely to the population on an twice every year, and this is very common, especially in the West, where flu and extreme weather, cold weather happens. That the populations there indeed actually get jabbed every year for flu. In the same way, COVID-19 is likely to be. Remember, COVID-19 is only two and a half years old. This is a disease that none of us seated here can actually say how it will pan out, because the experience that we have is so short. So we are still learning, but evidence is after 6 to 8 months, the immunity that you get from the last dose of vaccination starts going down. You need to boost, and that's why we call it a booster dose. You need to boost your immunity so that you raise it up again. And again, after 8 months, it also starts going down. You want to boost it again. So this will be continuous.
So the booster shots are necessary?
Yes.
Okay. Dr. Maritim, there's an issue about vaccine that is reducing the lifespan of children and AstraZeneca causing blood clots.
Yeah. So the question from the back about the vaccines given in children and reducing the lifespan. None of the vaccines that we have, again, they've been administered for a fairly short time. There is no evidence to suggest that they'll do something that will cause someone to die prematurely. So we don't have enough evidence. We need to follow up all the people who've been vaccinated over some time. But from the science of the way the vaccines are designed, we don't have any basis or scientific basis to say that that concern can be true. Because sometimes, unless you're saying it's going to cause something that will cause someone to die, we don't have a very clear scientific evidence to say that it will actually result in someone, if they receive the vaccine in childhood, that they'll die early. The second concern is around the clots by AstraZeneca vaccine. So around last year, mid last year in 2021, there were some reported cases once the vaccines were being used in a wider community setting, particularly reported in Western Europe, countries of Britain, Germany, and other countries in the European region, where they noted abnormal blood clots in people who had received the AstraZeneca vaccine. And these clots were unusual because they were occurring in places where we don't typically expect clots. So one of the things we have to understand, for some of us who've taken care of COVID-19 patients, one of the most feared complications in the COVID-19 patients is that patients were actually developing blood clots. They could develop the blood clots in the lungs, blood clots in the legs, blood clots in the brain. So when the vaccines were administered and these cases started being noticed, there was a lot of concerted effort to investigate and find out where are these clots occurring, what is explaining these clots, and some of the evidence that was found is that they were occurring within 4 to 28 days after vaccination, particularly in the women population and who had received the AstraZeneca vaccine, and it was more commonly reported with the second dose. Remember, we talked about the vaccine being given as 2 doses, so there was a lot of concerted effort, and I know there were these sentiments about it affecting even the deployment of vaccines in other African settings. At that particular time, we had 2 places where the AstraZeneca vaccine was being manufactured. There was a company in Korea, SK Bio, and then there was the vaccine that's deployed in a lot of sub-Saharan African countries, which was being manufactured in India. So it was the same vaccine, but in two different places. So there was a lot of concerted effort to try and get data from other vaccinating regions reported through the pharmacovigilance system that I talked about earlier, which is a safety where you report all the safety concerns and reports. In Africa and India, where a large proportion of people receive the AstraZeneca vaccines. Finally, there's been an association that's been confirmed, but it's thought to be that there is a predisposition within the individual. It's been described more in the Caucasian population, but in African setting, we haven't had reports of similar clot. So there's still, the jury is out there, but there is an association between that clot and also has been reported with J&J in some cases in the America where it's been used as well.
All right, I have to take a quick commercial break. When I come back, Dr. Luga, I'll allow you to respond to some of the questions that have been raised, and then I'll take another set of questions here. Plus, there's quite a number of them coming through on Twitter. I'm sure we'll not finish all of them by tonight, but there's a conversation worth starting. It means people are interested and it's igniting a conversation around the efficacy of vaccines and why they need to be done. All right, let's take a quick break. We're back with more in just a bit.